Cool. This is going to be online. It's actually online already, so everything you say now will be used against now. I can promise things. Well, very cool. So we have part of the thing. I'm going to be Palmer. The usual things apply. Obviously, like you got your bachelor's from the University of Adelaide in Australia. I think you recognize the accent. But it's been quite a few years since you left sunny Mediterranean sounding southern Australia and went to work in Harvard, where he got his PhD and did a postdoc with Peter Sorger. And move on to I would say greener pastures, but not necessarily greener, different pastures.
It's very green.
Yes, so it's Boston, I suppose. No, not Boston, probably not. To UNC in North Carolina, where he's an assistant professor who has been recently been funded with an R01 and got plenty of funding as well from pharma. So those are the traditional things.
Not really.
Not really. Someone, but someone. It's fine. But the point I was really trying to make, though, is that those are the standard things. The important thing to us is his science, and his science is remarkable. He's been published in really interesting articles in things that are very interesting and important to us. So either you are involved with the Center of Excellence or you are interested in cancer evolution. A lot of what we do is try to come with clever ways to apply existing treatments to basically control or cure cancer. And you've been a leader in this field. You've been actually doing really remarkable work, and this is what we want to listen to.
Great. Thank you so much for the introduction. All right, yes, so I'm so excited to be here. As I mentioned to Sandy, I've been seeing photos of this room and all the fantastic seminars that have happened in this institute. I've really been inspired by the work happened in the mathematical oncology program here. So it's a delight to come and talk to all of you. All right, so we're going to talk about models that are being used, that we're using to understand and predict the clinical efficacy of combinations of cancer therapies. And I will summarize at a very high level how it is that this is possible, and it is to understand that drugs for the treatment of cancer don't have a homogeneous effect in patients. Instead, they work well for some people, not well for others. The activity of a drug is described by a distribution of effects. And the general concept that I'll describe here is that if you have the clinically measured distribution of effects of drug A and the clinically measured distribution of effects of drug B, it's possible to fairly accurately predict the clinical distribution of effects of drug A added to drug B. All right, but to step back from that, why are we talking about combinations of cancer therapies? It's because trying to treat cancer with one single drug generally does not work very well. There are some exceptions, but for the most part, most advanced cancers are treated with combinations of multiple drugs. And in types of cancers that can indeed be outright cured, cures are almost exclusively achieved with the use of multiple drugs in combination. Right. So the need to treat cancer with drug combinations was apparent from the earliest clinical trials of single chemotherapies, where the limitations of using monotherapy were apparent due to two different forms of tumor heterogeneity. The first about patient-to-patient heterogeneity, where it would be seen that even given one active chemotherapy, it would induce responses in some patients in the population, but not all. And then the second dilemma being intra-tumor heterogeneity, where it would be seen that even when a patient has a response to a chemotherapy, it would kill some fraction of those cancer cells, but not all of them. And certainly in the early days of chemotherapy for acute leukemias, it was inevitably the case that after a response to one drug, the cancer would grow back afterwards and it would be resistant to retreatment with the same drug. It was again immediately apparent to people in the field of oncology even in the 1950s that drug combinations could help resolve this problem, and they were inspired by the success of multi-drug combinations in curing tuberculosis. And the concept was that if you have some fraction of cells that could be killed by drug A and some are resistant to it, and some fraction of cells that be killed by drug B and some are resistant to it, then if you combine the two drugs, a fraction of a fraction will be surviving both drugs in combination, right? So you could take the surviving fractions and multiply them. And what this looks like on a logarithmic scale is if you think about the magnitude of drug effect as a certain number of log kills or steps down on a log scale, this multiplicative principle is just adding up effects on a log scale. This is also known as the Bliss independence model. When they ran clinical trials of multiple drugs versus single drugs for the treatment of acute lymphocytic leukemia, which is where most of this early work happened, they then saw a completely different phenomenon related to the patient variability. So what's shown here are individual patient outcomes for a trial published in 1961. And the trial had three different arms. It was given two drugs, mercaptopurine and methotrexate. It was Some patients got drug A until the failure of the treatment, and then they swapped to drug B. Some got drug B, and when that failed, they swapped to drug A, and then the third arm of the trial were given both drugs at the same time. This is all of the data for the patients in the sequential arms. And the significance of the sequential arms is they were given one drug at a time, and you could know whether the tumor responded to drug A or if it responded to drug B. And so what we're seeing was there was some fraction of people who had a complete response to mercaptopurine, some fraction who had a complete response to methotrexate, and then a fraction that was responsive to both drugs, right? And again, some people who didn't respond to either treatment. But from these results, they're able to understand that given the response rates to the two single drugs, you could do this very simple bit of math to say the response rate of the drug combination is the response rate of one of the drugs plus when that fails, maybe the other drug works. And from that, you could calculate the expected response rate to two drugs in combination. But then they expected a 44% response rate. What they observed was that among patients who got the two drugs in sequence, 44% of patients had a response at some point in either getting the first or second treatment. And then in the third arm of the trial where both drugs were given together, in that case, you can't tell which one of the two drugs contributed to response, but 44% of patients responded to the two drugs in combination. So it was saying that this phenomenon of patient-to-patient variability was why the response rate went up for two drugs. Just you increase the chance that at least one thing works. So coming back to this picture then, you can see two different ways that combination therapy can improve outcomes, right? At the population scale, more patients will respond to combinations of active therapies. And at the intratumor scale, if you have a patient who is indeed responsive to two drugs, then you could kill a larger fraction of cancer cells and get a longer lasting response from putting them together. It could be another phenomenon where you could have a synergistic drug-drug interaction, where there could be cells or patients who are resistant to drug A and resistant to drug B, and the two drugs together have some positive interaction so that they have an effect that's more than the sum of its parts and is able to induce a response. And what I'll show you is that this actually has a relatively minor contribution to the activity of clinically approved cancer therapies. Heterogeneity is demonstrating most of what's going on among successful treatments. So I'll talk first about this part of considering the interpatient variation in combination therapy. And we're going to come here to looking at human clinical trial results. And so the way they're measured in most contemporary trials are these Kaplan-Meier survival curves showing the percentage of patients who are alive or the percentage of patients who are free of disease progression as a function of time. So every little step down here is one patient having like disease progression. And so what this is showing is this is the result of a clinical trial in metastatic melanoma, where patients were treated with either one checkpoint inhibitor called ipilimumab or another checkpoint inhibitor called nivolumab, or a combination of the two different immunotherapies. So this one only works for a small fraction of patients, this works for more, and then the combination is the most successful of the three arms of this trial. So what Peter Sorger and I showed a few years ago was that you can take the same logic that was described in the 1960s to response rate and apply this to this time series data on percentage of patients with progression-free survival. And there's the expected probability of response to drug A and B is the chance that drug A works, plus if that doesn't work, maybe drug B works. And then there's also a term here accounting for the cross-resistance between the drugs, the degree of correlation. And we're here accounting for the fact that if there's some cross-resistance between the drugs, then a patient who is resistant to drug A might be more likely to also be resistant to drug B. And the prediction made by this model in the black line is pretty dead on the observed clinical trial result. So this says the reason this multi-drug cocktail is more successful than either monotherapy is this phenomenon of patient heterogeneity.
So did you fit to the nivolumab to get that combination?
So, for in this model, P of A and P of B, those are the clinically measured curves.
Right.
Yeah.
And then you had to choose P.
So this here, what we did was we looked at large databases of like drug response correlations in like xenografts and cell lines, and what is generally seen for like different mechanisms of drug action was on average 0.3. And so we didn't have data for the correlation for these particular two drugs. Certainly they don't have it. You're gonna have a very hard time measuring their activity in preclinical models. And so we relied on the fact that sort of across all combinations of mechanistically different drugs, the average correlation is 0.3. So in this paper, we looked at lots of drug combinations, and we just used 0.3 for all of it.
Oh, so you didn't fit it, you just.
No, we didn't fit it. We just like the preclinical data says it's generally around about 0.3 for different mechanisms of drug action, and we just roll with that. If you change that higher or lower, the curves go up or down by like 2%. So it doesn't matter very much. All right. This paper happened to come out before most clinical trials of immune checkpoint inhibitors added to other therapies, which, as you know, in the last few years, the field of oncology has been revolutionized by adding immune checkpoint inhibitors to other sorts of existing therapies, chemotherapies, targeted therapies in all sorts of different cancer types. So this was a really marvelous way of testing, sort of prospectively testing the model. So, besides this melanoma one, we had longer follow-up there, but besides the melanoma one, these are all trial results that came out after this paper. And in here then, the black lines are the model predictions, the blue lines are the phase 3 clinical trial results. And you can see this model is explaining the vast majority of trial results very accurately. There's one outlier here where the observed effect was far inferior to the model prediction. And what happened here was that this was a 3-drug cocktail, which was very poorly tolerated. Over 90% of patients needed dose reductions or interruptions. So in a case where you can't actually administer the full doses of the drugs, then they're going to underperform relative to model expectation. That was like the one outlier.
Can you account for those things in the model?
If you knew, you would need to know how much does the activity of one of these drugs change as you lower the dose. If you have clinical data on how much does the progression-free survival curve lower at lower doses, then you could very easily put that into the model.
But this is something you can get.
If you don't have data on that, then you're really out of luck.
But there's a lot of patients who don't get 100%. So there must be a lot of data out there of what the impact of.
It's not always published in a granular manner, right? Sometimes it's published, but more often you don't have a lot of information on it. Yeah.
How did your model change with the triplet therapy?
So actually, right, this is a relevant point across many things here. We're sort of modeling like A and B to predict A plus B. Yeah. Sometimes A is multiple drugs itself, and in that case, we just, one of these terms is just the clinically measured effect of like 2 drugs, and then this is a 3rd drug, and we're predicting the effect of the 3 drugs.
Is this with like chemotherapy, general chemotherapy, or like a checkpoint inhibitor, so it's immune related? Is this always like 1-on-1, or there is like a mix of things that can be like, and you see a difference when you try to predict?
What sorts of things you pair up?
Well, yes.
Yeah. So across here, there's some of these are chemotherapy plus immune checkpoint inhibitors. Some of these are like tyrosine kinase inhibitors added to immune checkpoint inhibitors. Right, and then this is like BRAF inhibitors added to immune checkpoint inhibitors, bevacizumab and chemotherapy plus checkpoint inhibitors. So this is mostly like chemotherapy or targeted therapies. It's generally based upon what was the standard of care for that disease before immunotherapy came along. We don't see any, if you sort of break this down by mechanistic class of what's being added to it, we don't see any difference. It sort of across the board complies with the model, whether it's chemotherapy or a targeted therapy.
But it's always like something with immunotherapy.
Yeah, in this particular paper, these were all checkpoint inhibitors plus other things.
So was that 0.3 the same thing you used?
Yes.
Because that surprises me that immune therapy behaved the same way as a drug.
Well, what we're supposing here with the 0.3 is that there is a very weak correlation between responsiveness to drug A and responsiveness to drug B. So what you get out of, I mean, if it was 0, you would be saying your propensity to be sensitive to chemotherapy has no bearing whatsoever on your propensity to be sensitive to immune checkpoint inhibitor. And running it at 0.3 is to say there's a little bit of an enrichment here. Being resistant to one class is sort of slightly worsens your outcome for the other. If you ran this all at 0, it would be marginally less accurate, but still within the confidence intervals of the trials.
I'm wondering about combination ICIs. So like ipilimumab and nivolumab.
Yeah.
I would have expected rho to be much higher, but because you showed though that it might not be.
Yeah. So
But then you said it's also insensitive.
So in metastatic melanoma, we have data on ipilimumab in nivolumab refractory patients, and it's not a lot worse than the effect of ipilimumab in like treatment naive patients. So it's in that case demonstrably the case that if you select for patients in whom PD-1 checkpoint inhibition didn't work, there's not a lot of difference in the degree of activity. It's sort of a slight reduction in the success of CTLA-4 checkpoint inhibition. So that is suggesting that they are sort of largely independent of one another. And then the other data set supporting that point is people have measured correlations between the expression. Actually, right, so this is getting a little bit outside of my immunological knowledge, but I understand people were able to sort of connect responsiveness to CTLA-4 or PD-1 to which classes of MHC is expressed in the tumor, and those are independently assorting in patient populations, suggesting that it's a low correlation.
And this is like sequential or a simultaneous treatment for the combination?
Oh yeah, here in the combination trials, these are usually given together. Yeah.
Sorry, one more. How do you count for different timelines? Like you have the time series for each one of these. Do you just have to go with the shortest one, or?
Oh, like the time series here?
Yeah.
You could see it as like making a calculation of every, at every point you're saying what's the rate of success of drug A and what's the rate of success of drug B, and that builds the whole curve.
So you're throwing a dice at the time?
There's two, maybe what you're getting at here is there's two different approaches to get the exact same result. One approach is to use this analytical thing where you sort of calculate P of A and B at every series of times. The second equivalent approach is to say you construct a joint distribution of response times to drug A and drug B, and you construct that to be partially correlated to the extent described by Rowe, and then you randomly sample points, and for each virtual patient you randomly sample some like a pair of responses, and then given response time to drug A and response time to drug B, you just take whichever one is bigger. So this is effectively a modeling right here. This is effectively a model of highest single agent. What we're modeling here is not even supposing that the effects add up in time, but just if one drug controls the tumor for 6 months and the other drug controls your tumor for 12 months, the effect of both of them is they control the tumor for 12 months because that's how long the best of the drugs worked.
And which way you implement?
They produce identical results as long as you run a large enough sample size on your joint distribution thing.
I'm wondering in the second case, how do you deal with the censoring? Like right censoring?
The Kaplan-Meier curve is produced as a result of accounting for the censoring, right? So there's patient data that's like progression events and censoring. The Kaplan-Meier method gives you the estimated distribution when accounting for the censoring.
I mean like the P of A, P of B, in the sample, how do you?
We construct the joint distribution from the measured distributions, not individual patient events, because otherwise you wouldn't be correctly accounting for censoring.
Yeah, okay, yeah, that makes sense.
Hey, my computer rebooted itself.
Oh, yeah.
It said Microsoft detected an error.
Can't use the blackboard.
Yeah, can I use the blackboard? Right. Okay. Let's go. What's the next slide after that? All right, okay. I know what to talk about after that. All right.
We can ask what you feel more comfortable, we can wait.
Yeah. Now, there's a point here about all of these trial results then are explained with just maybe drug A works or maybe drug B works.
Mm-hmm.
Many of these things were justified by some argument as here's why the drugs are going to have a synergistic effect, how chemotherapy is going to boost the immune system. Never mind that the patients are hospitalized for immunosuppression.
Yes.
The argument was made that, it will boost the immune system. Even though we're ablating your bone marrow, it's going to boost the immune system and boost the effective immune checkpoint inhibition. Mm-hmm. And all of this analysis of phase 3 human trial results says that's nonsense. That's not what's actually happening in these clinical trial results. Mm-hmm. So then you might ask, so what do you actually need of a combination therapy? Hang on, I'll log in here now. I mean, these things are successful, life-changing combination therapies, and it's not because drug A enhances the effect of drug B. It's because drug A has substantial anti-tumor activity in some patients, drug B has substantial anti-tumor activity in some patients, and more patients will experience tumor control from combining the two drugs.
laser crash thing, because you were wondering.
Right, I was wondering that, I thought he was gonna go in and do some improvisation on the board there. but-
That was the intention, that's right. But as soon as we need slides and this
I sort of something to sketch, and then I thought I can make the point without drawing. Rejoin Zoom.
So does that mean that intra-tumor heterogeneity could still account for it, but you can treat each of them separately as populations and only account for the inter-tumor heterogeneity?
So in these particular settings of it, so there's a second half of the talk talking about intra-tumor heterogeneity. In these particular disease settings, they're mostly incurable advanced cancers, so the treatments are not able to get to the point where they overcome intra-tumor heterogeneity so well as to be curative mostly. Although some people have like exceedingly long-lasting responses to checkpoint inhibition, but that's a very different phenomenon from like log kills adding up to cure that you get with like chemotherapy combinations in blood cancers. All right, hang on. All right, hope we're back. All right, okay. So from all of these trials, you can look at this also as like observed effect versus predicted effect. There's a whole pile of different cancer types here. Some of these trials met their efficacy endpoints and led to FDA approvals. Some of them did not meet their efficacy endpoints and did not lead to approvals, but they're all doing what the model expects them to do. So like the difference between successful or unsuccessful trials wasn't like, was there a different type of drug-drug interaction, but just were the drugs active enough to be expected to improve outcomes. Right. So I want to come down to the part that we were not even technically adding up effects. And this comes to this question of like the meaning of drug synergy. And in preclinical settings, there's sort of rigorous quantitative definitions of like when do you have a drug-drug interaction. And they can be measured by like isobologram analysis or like Loewe's method, where you're saying is the potency of a combination better, like a really low dose of drug A and a low dose of drug B together is doing as well as a really high dose of either single agent. Or this like bliss independence model, you're saying is it better than just multiplying the survival fractions? But clinical synergism has never been precisely defined. And that's been sort of established for decades, and there hasn't been an answer to like, well, what do we actually mean when we say synergy in a clinical setting? It has been, people have written a lot about, well, synergy means more than additivity. So what's been missing is a definition of what is additivity when you're looking at a human clinical trial results. So this is a paper addressed by Heian Huangbo in my lab that just came out recently, and defining a model of drug additivity for progression-free survival data for human clinical trials. So at the simplest look, you could say if you have some measured time for disease progression from drug A, and then you have data on how long does drug B delay progression if you give it next. Well, if you just add those times up, that's your very simple definition of additive effect of progression-free survival times. One thing we need to account for is that measuring progression takes time, even in the absence of effective therapy. Like sometimes there's trial arms that give no therapy at all for like heavily refractory patients. And it takes time for a tumor to grow, but one usually sees disease progression at the first scheduled radiological scan time. So if you add like 3 drugs that all progressed in 2 months, you shouldn't add that up to 6 months, because progression at 2 months means the drug did nothing. So our model for progression-free survival additivity is the effect of A and the effect of B minus that first scheduled scan time, because otherwise it would be like just sort of double counting measurement times. Right? And then the complexity here is, as I said at the start, is that it's not one magnitude of effect. You can't say the effect of a drug is 6 months, say. It's a distribution of effects. And so what we have here when we talk about drug additivity in human trials is there's some variable effect of drug A added to some variable effect of drug B. So the familiar example of adding variables is like rolling 2 dice and adding them up, right? And you want to get this distribution where like 2s and 12s are less common and 7s common. You can draw that as a 1 minus a cumulative distribution function. That's a survival function. So what we're doing with progression-free survival curves is really the same math as rolling 2 dice and adding them up, except we're doing that subtracting the scan time, and we're accounting for partial correlations between the drug responses. So Hannah applied this model to 25 years worth of FDA-approved drug combinations for the treatment of advanced cancer, looking for all the cases where we could find dose-matched monotherapy data. So in the same disease.
Every advanced cancer.
Sorry?
Every advanced cancer.
Every advanced cancer where we could find dose-matched monotherapy data and where there was an FDA approval.
How much data are we talking about?
We read like 300 clinical trials. Now, this is not 300 trials here, right? Because there's a subset of them where you can find all the right data sets all lined up, ideally. Yeah. All right. So amongst all of these trials here, then, the black lines are the observed clinical trial results, and the red lines are the prediction of the additivity model. And we have about 5% were significantly more than additive at a significance threshold of p less than 0.05. Most of them were dead on additive, and then about a quarter were significantly less than additive. But if you look at these, again, as a plot of like expected versus observed effect, a perfect prediction would be a straight line along the diagonal. And these are all these different Kaplan-Meier curves plotted in this manner. It's sort of generally quite good. And from a categorical point of view of like, would you predict the trial to succeed? 100% of these positive trials would have been predicted to succeed by the model of additivity. The largest source of error here is that sometimes things underperform expectation, but they were still expected to succeed by this. We then wanted to ask, is this an overly optimistic model that just sort of predicts success more than it should, or does it really distinguish between things that succeed or fail? So we then went and read another few hundred clinical trials. We looked at a 5-year interval of just all published phase 3 trials in advanced cancer of drug combinations to try and find cases where there was dose-matched monotherapy data. Again, that was hard to find the case where you've got all the right data to do this just right. But here then, every one of these dots is a clinical trial. The ones in green were clinical trials that did significantly improve progression-free survival, and the dots in purple did not improve progression-free survival. You can see the ones that did succeed, all of them had a more than 50% expected chance of success. Most of them were very robustly expected to succeed. And the ones that failed, most of them were expected to fail. Indeed, the bulk of them very confidently expected to fail. So drawn as an area under a receiver operator characteristic curve, it had 100% sensitivity and 78% specificity. So you can pretty reliably spot the difference between which drug combinations will succeed or fail in a clinical trial based on the monotherapy efficacy. So I want to come back to this point about synergy of, is it disappointing that we've seen that all these successful combinations were additive rather than synergistic? And I want to explain here that synergy doesn't mean more effective. Well, so you can think quantitatively about the effect of a synergistic drug combinations, the effect of drug A plus the effect of drug B plus some bonus effect due to it having an interaction. Right? And if you've got some positive interaction term that's by definition it's better than those drugs would have been if additive. So does this mean synergistic drug combinations are better than additive drug combinations? Well, now we're talking about comparing different drug combinations, like drug A and B is synergistic, they've got a bonus term. Drug C and D are not synergistic, they just have an additive effect. So does this synergy mean that this has a larger magnitude than that? Well, no. A and B might have different magnitudes to C and D. If you did a preclinical experiment where you dosed every drug at matching efficacy, so you gave everything at IC50, then the most synergistic combinations would be the most successful ones. But in the clinic, some drugs are more effective at treating cancer than others. And the mere fact that some molecules are better at treating cancer means that all bets are off when it comes to deciding does synergy identify the most successful drug combinations. This could be a 1 + 1 makes 3. This could be 5 + 5 makes 10. 10 is more than 3. That could be the more successful combination. So I have to sort of end this point saying now finding that most approved drug combinations are additive doesn't mean they're somehow inferior to hypothetical synergistic combinations. The main finding of this is that they are predictably successful, which is a good, useful thing. All right. I think I can skip this part. All right. I do want to mention this. All right. You can imagine observe predicted effect versus expected effect. If something's dead on the expected effect, we call it additive. If it was not on that diagonal, we'd call that synergistic. But if these had the same actual effect, we say they're equally good. This isn't better just because it has that name. And in practice, you see synergy often among weaker agents, sort of where synergy is more commonly detected.
So one question though, those are very important points, but if you have these synergistic drugs that are actually not very good in combination compared to other combinations, why are people using it in the first place? Like from the clinical standpoint, if I'm a doctor and these things are synergistic but not very good, then they're not very good in isolation either, so I'm not probably using that in the clinic.
Yeah, so they're not really using it in the clinic, but they go into clinical trials a lot.
Why?
And predictably fail because it's mechanistically interesting.
Oh, okay.
I wanted to say here, if something's, the activity is on the data, they were just additive, it's just doing what you expect, there's no funny business here in terms of drug-drug interaction. Kind of boring. When something's off the diagonal, there is evidence of some drug-drug interaction. If it's doing a non-additive effect, there must be some interesting mechanism behind it. So the lesson here is, if that's where you're at, mechanistically interesting does not mean effective. But this is a point of hot debate in oncology at the moment, that there's people saying what you really need for a combination therapy is a mechanistic rationale. And the competing view is what you really need for a combination therapy to be safe and effective is you need the constituent drugs to be safe and effective, which doesn't include the words mechanistically interesting.
Also doesn't make me feel as clever.
Yeah,
Yes.
I think certainly on translational space, people want to do clever things, and that's desirable and useful in general. My own take on this, I think the role of mechanistic understanding, you need mechanistic understanding to develop good single drugs, and you need mechanistic understanding to be able to find what sorts of subsets of patients or disease subtypes it's going to be most successful in. But when it comes to justification for adding two safe and effective drugs, you don't need a mechanistic rationale to combine them if they're safe and effective. And conversely, if you have a drug with no single agent activity in a particular disease, I don't think the evidence is that mechanistic rationale doesn't overcome the drug being inactive and make it active.
Could finding out the mechanistic interactions in low effective but synergistic drugs allow you to figure out things that might make better drugs become synergistic? That is, maybe the combination itself is not interesting, but maybe I learned something about these interactions between these two drugs that might allow better drugs to interact better, especially the ones I'll design in the future if I'm a pharma company.
Yeah, I certainly think studying reasons for why one drug has failed can give you insights how to make better drugs.
Yeah.
And indeed better drug combinations. I think that the historical expectation is that you should anticipate that things should be additive when combined. There are two examples I know of in my lifetime where things were actually clinically useful and synergistic, and that's leucovorin to fluorouracil and cetuximab plus encorafenib in BRAF mutant KRAS wild type metastatic colorectal cancer, which is a very particular genetic context where there's two different sources of oncogenic signaling and they have to be both taken out.
But the point you made, and I think it's very clear to me, is that if you just take two random drugs, and you have to put your own money into this, you have to place a bet, you just go for additive, right? Because that's the likeliest option. But that's because you have no power about these two drugs. You just pick two drugs and you know nothing better. That's what you do. But if you actually had a more mechanistic...
So you should prioritize them based on their observed single agent activity in the indication.
Yeah. But as we develop new drugs in the pipeline, you're a pharma company, but then you want to make sure that you learn something about mechanistic interactions that would allow you to provide better. Because I feel like we move to a future where combinations are going to be the default, right?
Yeah.
So you should design your drugs thinking of combinations in the first place.
Yes.
So wouldn't these interactions become more and more important as we move forward that future?
No. I don't think so. I think you want to find who's the patient subset, go back to this kind of drawing. If you could enrich for giving the red drug, if there's some biomarker for who are these people who the red drug is not going to work and don't give that to them, mechanistic insight will tell you how to find useful biomarkers like that. So that's where I think the most useful role for mechanistic insight is in the development of combinations, and it's saying who should get which drug in their regimen. All right. Okay. this was a simple phenomenological model that I showed you, just sort of adding up times to progression. But there are cancers that can be outright cured by drug combinations, and just sort of adding up finite times will not add up to like cure. And so we really have to think more deeply about intra-tumor heterogeneity, because to get to a cure, you need treatments that overcome intra-tumor heterogeneity. And this is a line of work that I started investigating in my postdoc with Peter Sorger and worked together with Christopher Chidley. But we wanted to study a 5-drug cocktail called R-CHOP, which is used to treat the most common blood cancer, large B-cell lymphoma. And this treatment cures about 2/3 of people with this disease, which is worldwide is like about 100,000 people a year. It's been around for 20 years. So it's cured over 1 million cases of cancer. And when we experimentally measured the interactions between these 5 drugs in sort of all different permutations of doublets or triplets or quadruplets or all 5, they're very close to this like multiplicative principle of the Bliss independence model. Some combinations of it are like antagonistically interacting, but it's overall mostly additive. I then wanted to look really deep with high complexity clone tracing to like measure multi-drug resistance events down at like a 1 in a million frequency. This is a graph that shows the fraction of clones in a barcoded population that have resistance to just 1 drug or 2 of the drugs or 3 of the drugs. The dotted red line here is the minimum theoretical cross resistance, which is this multiplicative principle, right? Like if 1 in 1,000 resist drug A and 1 in 1,000 resist drug B, then at least 1 in a million will have double resistance, just as a statistical accident. And the observed effect is not quite that low because there are some multi-drug resistance mechanisms, but it's fairly close to that. So it's fairly well following this multiplicative principle. And that's how it gets to cure. It's just highly active individual agents in combination, no synergistic interaction between them, even in a curative treatment. So one way of thinking about this then is that you can consider the number of cancer cells on a logarithmic scale. And if you have the magnitude of effect of each different single drug, then when you combine them, they just sort of add up on the log scale. And this was a concept that was around in the 1950s and 60s. And in fact, the first 4-drug combination that was used to cure pediatric leukemia was motivated on a model that's exactly what I've drawn here. They understood that a complete response to a single drug would produce about a 3-log kill. They estimated that there were about 1 trillion leukemia cells at time of death by careful cell counting. And they calculated then that if they were going to reduce 1 trillion tumor cells to less than 1, they would have to combine at least 4 drugs together to get to that. And so this simple calculation is actually the justification for the first multi-drug cocktail to cure children with leukemia. And we wanted to revisit that model and account for the fact that the patient heterogeneity in here. So the way we're going to revise this is to account for the fact that across different patients, any one drug doesn't have the same magnitude of effect. It has variable effect. And so then as you put multiple drugs together, this is our mental model of what a multi-drug cocktail is doing in a patient population. Different drugs adding up different magnitudes of effect in like every individual, which is sort of complicated to look at, but it's actually quite tractable for a mathematical model. Essentially, the work from Han Huangbo earlier was this with just 2 agents together in the time domain, and here we're doing it for like poly combination therapy, thinking about log kills. So this was work published a couple of years ago by a postdoctoral fellow, Amy Pomeroy, in my lab, and we're taking this model of, we took the clinically measured distributions of effects of single chemotherapies from like trials in the 1960s in acute leukemia, and modeled like adding them up, and this is the outcome of the model. And so as the number of chemotherapeutic agents increases, sort of getting more and more kills, and when you get to 4 different drugs, a few people are lucky enough to get to the point of being cured. And this is what was seen clinically. They couldn't cure anybody with 2 or 3 drug cocktails. 4 drug cocktails cured just a few, not most. The response rate was very high. That's like 3 log kills will show up as like a complete response. So, you know, the first time you start combining drugs together, your response rate goes up, but cure is strongly lagging. And, you know, even here, you'll have some people who their first 4 drugs didn't work very well. They're nowhere near cure. It's going to take lots more chemotherapy to get them cured. But every time you sort of add more and more active agents, a few more people cross the line, and the cure rate gradually increases. But it takes very intensive regimens to get a very high cure rate, which is what we have today in this disease. So in this graph, then the solid lines are the historical clinical data. and the dotted lines are what's expected by this simple model of independent drug action. So this model is far more simple than what's really going on in the treatment of this disease, but it illustrates the relevance of thinking about intra-tumor heterogeneity together with inter-patient heterogeneity in multi-drug combinations.
Is your prediction like has no variability in it? Is it because
Like why are there error bars on the expectation?
yeah.
We just fit to the monotherapy data.
Right.
So basically what we get out is actually quite simple. You essentially have the single drugs have a distribution of effects, which on like clinical data is very closely fitted by saying it's like a normal distribution. It's essentially 2 log kills on average and a standard deviation of plus or minus 2 log kills. And then you just add all that up and that produces this.
Why does it tail off like that compared to the expectation?
I'm sorry, which part?
The cure,
The cure.
the orange.
Oh, why is Q lagging?
No,
No.
like
No,
the
the
tail
tail,
off
the-
at the end.
Oh.
You can see how it's.
That in the clinical data, I'm not sure. Certainly we're modeling it, this is a very simple conceptual one. This is modeling it without correlations. There's issues of like pharmacological hideouts, like some of the real challenges that were actually happening here as they pushed up was like going from 4 to 5 was using intrathecal methotrexate to get leukemia that's crossed like into the blood. Crossed the blood-brain barrier and gotten into the brain. So there's a lot of pharmacokinetic complexity that's not being explicitly accounted for. There's pharmacokinetic and physiological complexity that's not accounted for in this simple model. But the next sets of slides are going to get into more mechanistic detail.
But it is kind of shocking how well it works.
Yes, I think what this convincingly demonstrates is that there exists inter-patient heterogeneity and intra-tumor heterogeneity in cancer. And that influences the success of combination therapy. Yeah.
So we have like 8 different drugs for these patients.
Yeah, that's where they were at in like the 1980s. People have since gone on to like 16 drug trials.
So you always have a, like whenever a drug doesn't work anymore, you always have an next one. It's amazing.
Yeah. Well, here these are not in sequence actually. The other part of like the kinetic complexity here is there'll be like a certain they can't give all these drugs at once. So some drugs are part of an induction regimen, and then when they've done a few cycles of those, they swap to other drugs for a consolidation regimen.
Oh.
When that's done, they swap to other drugs for a maintenance regimen. It's like 2 years of chemotherapy to get to like. You could cure a lot of people without that much treatment, but you'd be curing a lower percentage. To get to a really robust cure rate, they kind of have to go like pretty hard. There's a lot of innovation in like tailoring intensity of therapy based on risk factors now. All right. So I want to get more mechanistically detailed than that. That just sort of lays out some principles. And so our approach is really modeling like dose response functions and tumor kinetics. We're inspired by the approach of population pharmacokinetic models. And the approach here is the idea that, if you measure drug pharmacokinetics, like the drug concentration in a patient's serum, these are sort of fairly well-behaved dynamic systems. Differential equation models describe these in humans very nicely, and you get, some distribution of drug kinetics over time. But what's seen if you measure this in a patient population is that all the parameters for this model vary between patients, like the drug elimination rate through your kidney or liver or what have you is variable between individuals. And you can measure in human populations distributions of rate constants for these things. And that supports this field known as population pharmacokinetics, where they build population level models where you use the parameter variability to describe the sort of spread of different outcomes of this dynamical system in like a virtual patient cohort. And they will calibrate these models on the spread of pharmacokinetics in patients in like early phase trials. So we took this approach to describing tumor kinetics. Now, we're not formally modeling like hour by hour pharmacokinetics here. We're just taking philosophical inspiration from that approach. That when you model tumor kinetics of like the tumors, there's some tumor cells dying and some resistant cells growing out. You can build models of these things with some parameters in them. We believe the same principle will apply, that these rate constants vary between patients. And then you can build like population tumor kinetic models where you describe the sort of spread of tumor kinetics. And so our foundational idea here is sort of going back to these very classic models of like cycles of chemotherapy and fractional cell kill, right? Where you have some number of cancer cells, and in each cycle of treatment, some number of cells are dying. This is our starting point, but we believe this is very simplistic, and we want to move from this towards being more realistic. The overly simplistic part of this is if you have the same fractional kill with every cycle of therapy, it would suggest that everybody could be cured with enough cycles. Right? If you don't kill much, just keep going, and you'll eventually cure everyone. We know that's not true. Sorry?
Don't kill the patient.
You'll kill the patient. Some drugs have like lifetime limits on administered dose. Yeah. Right. And so we understand that this sort of model would be true if there was one dose response function that described all cells in the tumor. Or in other words, that in terms of drug sensitivity phenotype, the tumor was completely homogeneous. And of course, a lot of very cool modeling work has happened from considering both sensitive cells and resistant cells in a population. We have some fraction of cells with a shifted dose response. They start off as a minority and over time they grow out and resistance takes over. So there's a lot of cool work has developed, new insights into the effect of like competition between resistant and sensitive cells in tumors using this two-state model. We want to be able to describe human trial results with this and the whole distributions of outcomes. And so we believe that these sort of two-state models don't describe these continuous outcomes, whether you look at like tumor volume change or progression-free survival curves. These are sort of more continuous outcomes. So we thought what we need to do is to model drug resistance and sensitivity as a continuous phenotype. So what's plotted here is the idea that within a tumor, there's some average phenotype. Some cells are more sensitive, some cells are less sensitive, and there's a whole spread. So you have within a tumor then an ensemble of dose response functions. And this will give you similar dynamics of like dying off and then things growing back as the resistant subpopulation grows out. And we believe that we should fit it to this sort of like log normal distribution because I experimentally measured it with like clone tracing and genome-wide CRISPR interference screens. And indeed, if you throw in a whole pile of genetic variability and look at all possible perturbations genome-wide of like knockdown or overexpression, you get a log normal distribution, which is what quantitative biologists in the 1800s would have told me to expect. So I want to talk about the math here. So like on this kind of two-state model, you could say the total number of tumor cells after a cycle of treatment is the number of sensitive cells times the number of sensitive cells that survive treatment, plus the resistant cells times the number of resistant cells that survive treatment. And if you want to describe that not as two states, but a series of states, then it's some sum over like ni's times fractional survival for those things. And if you want to describe it as a continuous variable, not discrete states, then it's an integral over some distribution function, n of x, and some dose response function, f of x, and the drug dose. So this is completely general in terms of any distribution of drug sensitivity phenotypes and any dose response function. This sort of integral can describe, different levels of killing when cells are in different states. And for the disease we're focusing on here, which is diffuse large B-cell lymphoma, we have the most experimental and clinical data to support this model. The distribution n of x is a log normal distribution. Well, x is normally distributed and 10 to the power of x is log normally distributed. And the dose response functions happen to be exponential decays as a function of increasing dose. So this is the equation we use for describing like one response to one drug in a heterogeneous tumor.
Why is that 10 to the power x?
We could use any base. We could have done like, I could have done e to the power of negative e to the power of. I feel like that would throw people off. I just chose to use it as base 10.
Right, okay.
The idea is that x is normally distributed, 10 to the power of x is log normally distributed.
Right, and
Yeah.
why the half?
That is just part of normal distributions.
Right, okay, so.
Yeah. And this is all just what happens with the normal distribution for like normalizing the area under the curve. Right. Oh, and maybe the part to point out here is that like 10 to the power of x here is relative level of drug sensitivity. And this is effectively multiplying the dose. So what we're saying here is that if a cell is at like 10 on the drug sensitivity scale here, it's as though they were exposed to a 10 times higher dose. Right? In a cell that's at 0.1, it's as though they were exposed to a 10 times lower dose. So that's the way we're describing relative level of sensitivity or resistance in this model.
You use one function, f, like capital F, you drop the subscript I, or do you have multiple dose response functions.
Oh,
for
right,
each.
yeah. So as soon as you're talking about multiple drugs,
Yeah.
then this becomes a multi-dimensional integral, a multivariate, not partly correlated normal distribution, and this becomes a multi-drug dose response function. And where this gets fun is your multi-drug dose response function, you can put drug-drug interactions in it if you want to. But you choose to model this with like potentiation or antagonism between the drugs if you want to put that into that dose response function term. It happens that for these particular drugs in this disease, they're additive for the most part.
Can I just ask, does that mean then that you never actually have true drug resistance?
You don't have drug resistance.
But would that be zero here?
Oh, you mean like sort of absolute drug
Yeah, it doesn't
resistance?
exist. Is
Um,
that what you think?
Well, I think this illustrates it here. So here then is like the distribution of states, and this is like how much killing they get as a result, right? So things on the sensitive side get killed very effectively, and things on the resistant side are like killed scarcely anything at all. So when I say like, is it formally modeled as the dose response is a flat line and nothing happens?
Yeah.
No, it's not formally modeled as that. It's modeled as just a shift in potency. But the shift in potency can be sufficiently large that in effect nothing happens at the administered dose. Yeah. So if you kill off more of one side and less of the other, then the distribution shifts. And what happens to the population across multiple cycles of therapy is that the distribution sort of shifts to the left. So the Darwinian selection for resistance just emerges from this model without us sort of putting in, mutation as a specific step. It just emerges. Right, so that was sort of the
But is that because you've got like a heterogeneous population you're sampling from, and as you treat, you then select?
Yes. Yes, that's right. Yeah. All right. So that was describing the intra-tumor heterogeneity, like say the patient here in blue, that's their distribution. And then we consider that among different patients in a clinical trial, they all have different average levels of drug sensitivity in the first place. So there's a distribution of sensitivity between patients, which then means that each patient has their own intra-tumor distribution of sensitivity, right? Like the patient in yellow, the whole tumor is quite sensitive to the drug. The patient in red, the whole thing is quite resistant to the drug. And this patient's sort of a mixture of some sensitive and some resistant. And when you have multiple drugs, you have like multi-dimensional distributions of sensitivity to different drugs. Again, like we model this as this like partly correlated multivariate normal distribution. This is the experimental data from CRISPR screens supporting our use of this equation in the model.
I have a question. If we were to look at the curve that's for one drug, right?
Yeah.
How would they compare if you look at different drug at the same time? Because they would be normally distributed, but not necessarily around the same dose, right? So, like, how do you pick the one, like the dose that gives you one? Is it the IC50?
I'm not sure I follow the question. The dose that gives, like sort of what's one here?
Yeah.
Oh yeah, so I guess this is sort of like relative to because this effectively becomes something that multiplies administered dose here. You effectively, when you make the model, you need to fit a parameter for what is the average level of drug sensitivity in all patients.
Okay.
Yeah. So that effectively sets that.
Clinical data or experimental data?
As I'll show you so we use the experimental data. The experimental data tells us this is a log normal distribution and this thing is an exponential decay. And then when it comes to saying, well, what are the actual parameters in humans, we fit to human progression-free survival data. So that's coming up in a minute. All right. So then you can run like virtual clinical trials of model like multiple cycles of therapy, right? And some people who are like really sensitive to multiple drugs get cured. Some people will respond but not be cured, and then disease relapses, and some could be refractory straight away. And from all these sort of outcomes in different simulated patients, you then build a progression-free survival curve in the virtual patient cohort. And this then reproduces this qualitative nature of like continuously distributed outcomes in human clinical trials that we sort of set out to explain with this model. So this then was work that Amy Pomeroy did in my lab, where she calibrated this model on like observed clinical trial results where like R-CHOP was established as a standard treatment for B-cell lymphoma 20 years ago versus CHOP. So this is, those parameters are fitted to reproduce the effective CHOP and rituximab plus CHOP. And here then is data, more recent clinical data, measuring the magnitude of tumor shrinkage in patients after their first cycle of therapy. So this is like partway through their treatment. And this is using circulating tumor DNA, which has a really fantastic dynamic range. So about 100,000-fold dynamic range to measure how much tumor shrinkage there was. And this is the simulated reproduction of the sort of spread of outcomes, which is sort of qualitatively, we're happy with how well this performs. One thing the model did, which we thought was a little odd, was that the simulation predicts that some of the most sensitive patients are cured after their very first cycle of therapy. We thought that was a little outlandish, and then we heard from a clinician who mentioned they had a patient who got their first cycle of R-CHOP, said, nope, I'm getting no more chemotherapy, and the disease never came back. So some people get cured by their first cycle. Though it is like a 5-drug cocktail, so it's not inconceivable that it can do that. Right. We wanted to stick our neck out and really say, how well does this perform as like a prediction tool? So Amy calibrated this model on historical data for rituximab plus CHOP, and then also used it to fit to data on a new drug called polatuzumab vedotin, tested in relapse refractory patients. So given parameters for polatuzumab by itself and the standard regimen R-CHOP, she then used the model to make a prediction of the result of a clinical trial that added polatuzumab to R-CHOP and actually removed the O, the vincristine, and replaced it with polatuzumab. And this was the model prediction, and she posted this prediction online before the phase 3 trial result was first released to the public. And this was the result of the phase 3 clinical trial, where the improvement in progression-free survival at 24 months and 36 months was like exceedingly close to the model predictions. Amy has since applied this retrospectively, because since R-CHOP was developed 20 years ago, lots of trials have attempted to add other drugs to this cocktail, and they'd all failed except for polatuzumab vedotin. And from this modeling approach, the only one that was expected to have a high statistical likelihood of success was the polatuzumab vedotin combination, the one that did succeed. How are we going for time?
You got another half an hour you want.
Oh, wow, okay, all right. Maybe I should catch my breath. And pause for questions at this point.
I don't think we wait for the questions, it's fine.
Sure, yeah, okay. So I think this is sort of confirming that we can use this model framework to use data on new single drugs to predict how are they going to succeed in a combination. These trials were sort of more complicated in their structure because some of them were removing, like this was rituximab was removed and replaced with obinutuzumab. Everolimus and enzasteroid were added as maintenance agents after the completion of the first 6 cycles of multi-drug chemotherapy, and using this more mechanistically detailed model, we're able to put in these like drug replacements, different kinetics of when drugs are used, and use that to make forecasts of what the clinical trial results will be. All right. Subsequent to that, a graduate student in my lab, Sarah Patterson, did a project that's a combination of experimental pharmacology and this clinical trial modeling to investigate the characteristics behind the success of this 3-drug combination, bleomycin, etoposide, and cisplatin, which cures the overwhelming majority of testicular cancers. Right, so this is a fairly common cancer type in young men, but it now has an exceedingly high cure rate with this 3-drug chemotherapy cocktail. So it's really one of like the triumphs of pharmacology to be able to get that kind of cure rate in a malignancy. So Sarah's approach was to do all the experimental pharmacology we want to inform this model. So she measured the dose response functions in a panel of testicular cancer cell lines, measured the heterogeneity in dose response functions to know sort of what's the patient-to-patient variability and sensitivity, measured the level of cross-resistance between the drugs, which came out to be about 0.3, and measured the drug-drug interactions between all these drugs across a panel of cell lines, where sort of the average combination index was 1, meaning additive, and there was a little bit of spread. Some combinations and some cell lines were a little bit synergistic, some were a little bit antagonistic, but it was fairly well centered on additivity. And then using that data, she then coupled it with data from a couple of hundred patients in clinical trials in this disease to get distributions of growth rates in these tumors and distributions of tumor sizes. And so these are sort of all these variables and distributions we need to run this sort of population tumor kinetics model. Then run virtual trials, calibrate those on the existing clinical trial data, and then use this model to investigate what are the principles that define treatment success here. And what we aim with this is to understand things in a way that would be impossible through human clinical trials. Because we have an established treatment with an incredibly high cure rate, anything that you might want to understand of like, how important is it to give, 4 cycles of therapy? How important is it to use all 3 drugs versus 2 drugs? Almost everything you would want to tinker with it would make outcomes worse and kill people. So it would be unethical to really understand why it works well in humans. But we can use in silico trials to tinker with this regimen and say which ones of its properties are most important for its success, or how do they influence its success. And then the other thing is you can go to pharmacological principles like the degree of cross-resistance between the drugs. So they don't have very high cross-resistance. Does it matter? It seems like it should be a good thing. Mm-hmm. There is no experiment you can perform to change the amount of cross-resistance between etoposide and cisplatin. It's an innate feature of those drugs' mechanisms. But in the model, it's a parameter and you can tinker with it and say, how much does that matter to the clinical efficacy?
We're convinced about the power of math modeling.
Yeah.
How do you relate the tumor dynamics now to the disease-free survival exactly?
So this is the same as the framework that you saw in this lymphoma model by Amy's work. So it's this model. Okay. It's this model framework.
Okay.
Yeah. It's with experimental data for testicular cancer and these particular 3 drugs. I'll mention the treatment is like all 3 drugs at the same time for 4 cycles. All right, so Sarah, fit the model to patient outcomes in those with most patients are classed as good prognosis and have incredibly high cure rate. Some are intermediate prognosis, some are poor prognosis. So Sarah fitted the model to these 3 different risk groups, and she measured a lot of things, either from experiments or clinically, and to fit to the human trial results, there were 2 parameters to fit. And it comes down to this distribution of sensitivity. So the average level of drug sensitivity has to be fit, and the degree of intra-tumor heterogeneity, right? How variable is this? That was another parameter that needed to be fit. So it was 2 parameters to fit these PFS curves, right? And as we'll show, the average drug sensitivity we find has to be different for these different risk groups. So this is a graph showing the effect of sort of relative sensitivity and how that changes the rate of disease-free survival at 5 years, or in effect, cure rate. And so these are understood to be innately chemosensitive diseases. And we can see here that this feature sort of relative level of sensitivity, which is effectively we model as a multiplier of drug dose, is pretty critical. And if this was even 2-fold less potent, you'd have a much lower cure rate. And the poor prognosis groups, the effect cannot be explained merely by the fact that they have more tumor in them. They sort of must be less sensitive to the drug, although this might be because of pharmacokinetic issues and sort of where the tumors are actually in the lungs for the most part. Right.
And this is for one drug or all 3 of them together?
Oh, this is for the whole 3-drug cocktail.
So it's kind of summed?
Because
the fact, the distribution,
we don't have the data to say, is one higher and is one lower and so on. So this is sort of shifting sensitivity to all of the drugs up and down on that scale. Yeah. All right. And then this is looking at the effect of using, what if you only gave 1 drug? That would be the blue bar here. So even in the good prognosis patients, the model prediction is that monotherapy, in the really good prognosis, really chemosensitive individuals, you might cure a few, but it would be pretty lame. And then the higher risk patients, monotherapy would be completely useless. The green bar here is interesting. This is, what if you gave triple the dose of 1 drug? It would do a little better in these people, but it's not nearly as good as doing the 3-drug cocktail. And this is that idea that heterogeneity is a multidimensional distribution, and there's some stuff on the tail that's sort of really resistant to drug A. And a higher dose of drug A helps a little bit, but not too much. But coming at it with a different drug, that's really what helps get rid of the drug A resistant cells. So using 3 different drugs really makes a huge improvement over just, say, tripling the dose of 1 drug. Toxicologically speaking, this is impossible. You sort of have to do different drugs to increase sort of net intensity because there are different dose limiting toxicities for the drugs. But this model prediction here is saying that even hypothetically, if you could crank up your monotherapy doses, it wouldn't be as good as using different mechanisms of drug action in combination.
When you do combination therapies, do they normally just add like a monotherapy dose?
Yes, yeah,
Okay.
for the most part.
They're not reducing. Okay.
There are occasions in I should say that data in Han Wangbo's paper earlier on modeling PFS additivity, we really limited ourselves to dose matched monotherapy ones and didn't permit ourselves to look at one where there were major reductions in doses of the drugs used in the combination. But what we see is that in trials where they're combining different modalities of drug action, I think that's sort of a lot of what's been happening in the past 10, maybe 20 years has been chemotherapy plus targeted therapy plus immunotherapy or antibody drug conjugates. Different mechanisms of action are being developed and brought to bear in combinations. And commonly these are tolerable without substantial reductions in dose, right? Some individuals need dose reductions after the regimen start, but most of what's gone to FDA approval have been things where it is possible to combine things at the full monotherapy doses. If you go back 30 to 40 years where really what was mostly in an oncologist toolkit was chemotherapy plus chemotherapy plus chemotherapy plus chemotherapy. In that era, there was a lot of cases where you had to give, we can give 2/3 of the dose or we can give 3/4 of the dose when things are put in together.
I don't know if this is the right time to ask this question, because I might wait to the end, so you can decide where you want to answer
Sure.
it. We're obviously interested in how treatment causes evolution in the cancer, which might then facilitate something like a sequence of drugs rather than a straight combination.
Yeah.
And there could be sequences which are actually better for the same drugs than others, right? Is that something that you've considered?
Something that we have considered, I don't know that we've sort of written a paper on this yet, but an idea that we firmly have in our mind is that on this thinking about the number of cancer cells over time, if you've got some treatment that's sort of, killing things down and there's a point where you're sort of killing as much as you can and you can't go further with the same drug, swapping to a different drug continue to push things down. And there's a lot of cases where other drugs have been added, sort of a lot of these things that failed in large B-cell lymphoma. They tried to, took a 5-drug cocktail and tried to sort of pack on more and ran into toxicity issues sometimes and had to you try to add more drugs and you wind up just having to dose reduce, and I think your net cytotoxic activity that's brought to bear is not any greater, even though you're using more drugs because of the dose reductions. And from our understanding that it's not that there's synergy going on here where one drug is potentiating the effect of another so much, it's just bringing in another powerful anti-cancer agent. I think there would be a lot of cases where instead of sort of compromising tolerability, if you gave, your finite number of cycles of the standard treatment and then swapped and you do your plus some extra drug at the end of your initial course of therapy, I think there'd be a lot of cases where getting enhanced tumor cell kill while having a tolerable regimen would be more successful. Yeah, this depends upon your extra drug having substantial activity in that particular indication. But I think it's there's this toxicity angle here of if it's not safe to give it all at the same time, give it after you finish your cycles of standard regimen, which, as I mentioned, has been for almost half a century now a mainstay of treatment for acute lymphocytic leukemia, right? Where they have an induction regimen, a consolidation regimen, some maintenance therapies, and that's the way they are able to bring a lot of anti-tumor activity to bear while keeping it tolerable.
I mean, that makes me think a little bit of kind of Bob's multi-strike strategy. But I was more explicitly in sort of thinking about the idea of resistance or sort of evolution in response to that first drug would make you more susceptible to one of the other drugs in some way.
Yeah.
Maybe not a full double bind, but somehow there is a sequence there that makes sense. So if you think about melanoma, you give your BRAF inhibitor, then you know it's going to go and use that other kinase. So you prop, but you don't wait till it gets there. You hit it before. You see what I mean?
Yeah.
So whereas if you maybe gave another, I don't know, I can't think, some metabolic inhibitor or whatever, basically it would just circumvent it, right? So you know that would make sense to give that second.
Yeah.
Right.
So actually, I'm gonna go way back here.
So everyone is doing that at the same time.
This clinical trial was motivated, this trial in 1961 in acute lymphocytic leukemia of like A then B or B then A or A plus B, it was motivated by collateral sensitivity.
Oh, really?
So there was preclinical data that if you take like I forget which way around it was, but if you take tumors that have evolved resistance to one of these drugs, they became more sensitive to the other one. So then they compared the sequence versus the upfront combination. Right? And what was observed in the trial was that like overall survival was just the same across all of the arms. But I think that what happened here was that if you think patients who are responding to one drug, like these people, they responded to it, but it didn't cure them, resistance developed and it grew out. Well, all of these people were entirely resistant to this drug in the first place. It didn't impose any evolutionary change.
Yeah.
It only imposed an evolutionary change in a subset of the patients. And then amongst those, the majority of them were like wholly insensitive to this other drug anyway, so whatever change happened wouldn't have altered it. Where a sort of induced sensitivity could have mattered would be here, and it could indeed have happened in that fraction of patients, but it's too small of a fraction of the whole trial population to be detectable. Now, this mathematics entirely depends on the fact that this was a setting where the single agents have like 25% response rate. So you're dealing with like a quarter of a quarter where the interaction would really matter. But if you have drugs in a disease setting, possibly selected by biomarkers, where you're looking at a drug that succeeds for a larger fraction of the patient cohort, and where some possible evolutionary change is like more prevalent in the patient population, then it could have a more meaningful effect. Yeah, so I think these sorts of things will depend on like identifying the patient subsets where the drugs actually work. Yeah. All right, okay. So we talked about cross-resistance. So here's sort of one way of thinking about what rho or like cross-resistance means here. If you have like a population of tumor cells represented by the area in this disk, some fraction of them could be resistant to drug A, some fraction of them could be resistant to drug B. If they just overlap as much as expected by random chance, that's a cross-resistance score of 0. Now, this doesn't mean there's no multi-drug resistance. It means there is as much as statistically expected. And as cross-resistance increases, there's more and more overlap, right? And at the extreme end, they're like, every way of resisting drug A also causes resistance to drug B. And so in this scenario, adding drug B is not going to help you kill off the cells that were resistant to drug A. So Sarah simulated how this parameter changes, effectively cure rate in this disease if you were to change that. And this is plotted for the patients with intermediate prognosis, where you get sort of a nice spread of different outcomes. And so the prediction here is that this is really critical to efficacy, that if they were fully, this is for like etoposide and cisplatin, if they were fully cross-resistant, you'd be doing very poorly. And if they had absolutely no cross-resistance, you'd be doing very well. The experimentally measured value is around about here. So it's got a favorable level of cross-resistance, but not the sort of theoretically optimal. But this sort of lays out that as a feature of a combination regimen with curative intent, it's really important to have low cross-resistance. So one shouldn't forget the role of like the chemosensitivity. If you were to take less active drugs that are non-cross-resistant, I don't think you'd improve things if they were just like less active drugs.
Just kind of a technical question, like, in the original formulation, you had 1 minus rho.
Yeah.
Sort of factoring in the second term. But in theory, you could think, if you have rho equals 1, you could also say that's the same drug.
Yes, that's right.
And
Yeah,
so
yeah.
You're saying you're adding more, you're doing a combination of the same drug with itself, you're effectively increasing the dose, but you're saying the PFS curve would not change at all.
Oh, this is not saying the PFS curve would not change at all so much as that it would not be a very good treatment. You could think of it as being like, you're completely correct to say like rho 1 is say it's like you increase the dose of one drug.
Right.
So you can look here at that intermediate prognosis patients.
Yeah, I mean, just
One
going
drug-
back to the original one where you had like the P of A minus 1 minus A.
Yeah.
But that formulation, I guess,
So
wouldn't work in that
That
case.
formulation of the model was not capable of describing dose response functions.
Right, so that's the difference, is that you have to include that, otherwise that is sort of not going to work
Yeah.
correctly in a way.
Oh, right. Yeah,
Because if you use that first formulation without it.
That
sort
first
of ignoring
formulation.
those changes,
Yeah,
right?
that first formulation was sort of saying like, 6 months of tumor control plus 6 months of tumor control. In the model of like highest single agent where they don't even add up, 6 months plus 6 months equals 6 months.
Right, so that's kind of the difference. Right.
But whereas if you doubled the dose, you might actually beat 6 months. So that model should not be applied to combinations of the same drug. Yeah, essentially because it cannot describe the effect of dose changes. Here, we're dealing with a model that is built out of dose response functions, and we believe we have some ability to estimate the effect of like dose changes. Yeah, so one drug for the intermediate group does terribly. If you were to increase the dose, it does a little better, but not a whole lot. So that's sort of what's going on with like row 1 here. All right, and here then is the effect of looking at multiple cycles of therapy. So we see different outcomes and different steepness of response here as a function of whether you look at the patients in the good, intermediate, or poor prognosis groups. The standard approach for a long time had been 4 cycles for everybody. And about 20 years ago, there was a trial that said, well, maybe for the good prognosis patients, maybe we don't need that 4th cycle. Let's drop it down to 3 cycles. And indeed, they saw there was no change in the cure rate in good prognosis patients, dropping it to 3. And so we were very happy that the model reproduced that clinical observation that of like the number of cycles that are needed here. Whereas like for the higher risk patients, they really need that extra cycle. And then the last part here, I mentioned that the experimental data showed these drug combinations are approximately additive in effect. But there's this very interesting thing here. As you model this, as you like increase dosage, you can sort of model this isobologram plot. This is showing the fraction of cancer cells that are still alive as you increase dose of the drugs, right? So with higher dose, there's more killing. And if they're pharmacologically additive, these are straight line contours. It means that like 1 unit of drug A or 1 unit of drug B does the same thing as 0.5 units of drug A combined with 0.5 units of drug B. So that's the effective additivity. And when we model these drugs as just having an additive effect in killing anti-cancer cells, when you look, this is like an isobologram plot made from a series of virtual clinical trials in a grid. It's effectively an isobologram plot on cure rate. And this looks like massive synergy, right? Because monotherapy is terrible at curing, but the combination of multiple drugs can get to cure, even though they're just pharmacologically additive. So when there's sort of no drug-drug interaction, the patient outcomes are utterly transformative with multi-drug treatments relative to the monotherapy. So like clinical outcomes look like synergy, though there's no mechanism of drug interaction.
This is cure assuming a threshold though, right? Like if you mathematically did this, it would look straight.
Yeah, this is assuming that below 0 cancer cells, or below 1 cancer cell, they don't grow back.
In other words, if you started with much larger tumors or something, then you would eventually return to the left side.
Yeah, I shouldn't say calibrated. An input to this model is the measured distributions of tumor sizes. So we're modeling patients having different amounts of tumor in the first place.
Yeah.
And one other feature of this, I don't have the slide for it here, but as you increase cross resistance, you lose this effect. And as you like decrease cross resistance, it becomes even stronger. Like if you were to have cross resistance 0, it would look like an even more obscenely strong synergy between the 2 drugs in combination.
But this is also, I mean, that's an assumption that you're making there. That's like an idealized split, and then you're generating this distributional response from fitting to.
So in sort of all these sort of models of clinical trials here, they are based upon a measured distribution of drug-drug interaction. So the experimental data is saying, as a function of combination index, which is a measure of like potency shift in combinations, like 1 is additive, 2 is antagonism. Like 0.5 would be like they're twice as potent when combined. The laboratory data across a panel of cell lines and drug combinations shows there's some distribution of these effects. And so when Sarah modeled these trials, she was modeling, each patient, their drug interactions are sort of sampled from this distribution. So it's assuming there's like a little bit of variation in strength of drug-drug interaction.
From the entire distribution.
She samples from this entire distribution, assuming like across different testicular cancer cell lines, there's a little bit of variation here. So when modeling different virtual patients, each patient's drug-drug interactions are sampled from this distribution. It's a little bit of noise around 1. It's mostly not really interacting.
I guess the reason why I was asking that is dose response curves to cell lines versus drug response in patients.
Yeah.
They're different things, right? And you're making that bridge by creating a kind of distributional type of response.
Yeah.
But I guess the thing that's fuzzy to me is, the experimental data is clean, but we don't know where in the spectrum the patient is. There's probably multiple sort of sampling that you could do that would generate the same sort of patient response.
Yeah.
Right? So
Yeah.
you make it look very clean, but it feels to me like
Well, so I guess what I can say is it's based upon the best available preclinical data we can get. And it has to be said here, there aren't a lot of testicular cancer cell lines, so we took all commercially available testicular cancer cell lines, which is about 4 or 5. It's not a lot. But we looked at all the different pairs. We did like all the pairs of drugs, all the triplets of drugs in all of the available cell lines to inform it. So it's the best data we can get. Yeah.
I'm not criticising that. I'm just saying I'm surprised at how well it works.
I think it's sort of we're getting some good qualitative insights here. I guess we get a little bit quantitative about like the effect of different cycles. I sort of see this as more of understanding the role of principles rather than expecting that this is dead on quantitatively what's happening in this disease. Yeah. And for this part, right, yeah, so the trial simulations before this point had variation in the drug-drug interactions because the laboratory data says there's variation in the drug-drug interactions.
Right.
For the purpose of this slide, Sarah held this strictly additive to illustrate the concept that even when you have strictly additive cellular effect, you get an emergent clinical outcome that looks like
that's
synergy.
important to show
Yeah.
that.
Right. So in general, sort of thinking about the principles of curability, yeah.
So I want to just go back to my question one more time. This is like a 5-year survival, but is the difference being entirely, is the change in like from, the linear gradient to the synergistic pattern, is that entirely due to cures, I guess, is my question?
Yeah.
Okay, so it's definitely like a threshold effect of like getting below the nadir below one.
Yes, that's right, that's right,
No,
yeah, yeah.
like secret like synergy arising from, okay, yeah.
Yeah, it's just like, when there's, I think the way it's formally modeled, because it's, that integral is gonna give you continuous outcomes. There's a point where we'll say like, oh, there's 0.1 of a cancer cell left.
Yeah,
And what we do formally when there's 0.1 of a cancer cell left is we say that there is a 90% chance that they're cured and you stop the model, and there's a 10% chance that there's actually still something left, like 1 cell. Yeah. Right. So to come down to these sort of principles, these things have been like described historically as part of what's going on in these regimens, and so we can see that the use of combinations of multiple drugs is essential to the success here. They need to have strong monotherapy activity to explain these outcomes. Low cross resistance between the drugs is really key in them getting to the point of cure, and multiple cycles of treatment is essential to the outcomes, particularly in the higher risk patients. But there's no sign of like synergistic drug-drug interactions in any sort of pharmacodynamic sense. So to conclude the whole talk here, so I've shown you that combinations of multiple active therapies overcome heterogeneity in multiple different ways, both inter-patient heterogeneity and intra-tumor heterogeneity. I've shown you that the efficacy of drug combinations in clinical trials can be accurately predicted by these principles. Most of the best combination therapies in clinical use, even curative ones, have activity that is consistent with additivity and therefore predictably successful. And I believe this demonstrates that simulations of combination therapy trials are ready to be used prospectively for clinical trial design. And both in cases of like retrospective analyses of clinical trials and prospective confirmations of model predictions, I think overall the accuracy of this approach is like comparing quite favorably to like the accuracy of modern weather forecasting. And I want to thank everybody in my lab whose awesome work makes my career a joy to have, and everybody who's sort of grew out of all of the work that I did in my like postdoctoral fellowship with Peter Sorger and collaborations with lots of other people, but were key to the development of these ideas. And thank you all for inviting me here.
I have not been calling on questions, but if there is any final questions to ask, do you have any? I know that you have lunch weekend after, so.
I think, the sequence question, I think, is an important one. and wonder if we could leverage some of the tools you've developed for that, because obviously there is a lot of data on monotherapies.
Yeah.
And there is some data on combination therapies, but there's very little data on sequences,
Yes,
because it's just never done that.
I agree. I think there needs to be more investigation of that, absolutely.
Right, thanks again.